My name is Cindy Manginelli, and I'm with the National Healthcare for the Homeless Council. And I'm really honored to be with you today and to talk about this topic of COVID-19 and the homeless population. If you're like me, I think every conversation I have when I encounter someone new, whether it's in my personal life or in my professional life, I feel like it's just inevitable that this topic is going to come up. And I think on some level, I kind of dread it. I kind of hope it doesn't. It's become such an emotionally and politically charged topic that it's almost impossible to have kind of a neutral, casual conversation about it. And yet the reality is that we would certainly be remiss to not mention this today, because in some sense, every conversation, every session that you hear today is going to be filtered through COVID-19 and through the reality of the pandemic and how it's drastically altered our lives and what we do, and certainly the lives of those we serve. So while I'm not super excited about talking about it today, I think it's absolutely essential, and I'm excited about the information that we're going to cover. We have 30 minutes today to talk about COVID-19, and so I'm certainly not going to spend that time telling you what you need to be doing and what you should not be doing. I think at this point you probably have filtered through a lot of that and understand a lot of that. So this is not going to be that kind of conversation where I tell you what to do or where I talk about what's mandated and how you have to respond. Instead, I'm hoping this will be a much more of a conversation just to kind of give you things to think about and how you're responding and how you're personally responding and how you're responding as an agency. I'm hoping it's a much more lighthearted kind of conversation and that you take away some helpful ideas, things that you can talk about with your team as you move forward. So we're going to talk first about some foundational steps that hopefully you've all already taken, just some sort of assumptions that you've done those things, but that we don't want to skip over just in case. Then we're going to talk about the primary issues that we all face as we move forward, and then sort of the secondary issues, or what a lot of people are calling the shadow issues of the pandemic, and different things that are those that we serve are suffering. We're going to talk for a few minutes about really creating a culture of health, and what does that look like? And then sort of remembering sort of a mission moment of why do we do what we do and how do we do that in light of the pandemic. Like many of you, my job changed drastically starting in March. In my role with the council, I visit homeless shelters across the state of Tennessee, and I help I help people with the sort of medical crisis, specifically with TennCare. So I help people enroll in TennCare. I help them navigate any issues they've had with it. I also meet with people who don't qualify for TennCare but have some sort of medical issue, try to figure out where can they receive care, that kind of thing. And then I also do trainings across the state, staff trainings, volunteer trainings. We do regional trainings. So obviously all of that was significantly or just kind of stopped for a long time. And we've gradually started doing some of that, but not anywhere near the scale that we used to do. And so in the spring and summer, because I couldn't do those things, I was doing some street outreach in rural areas. There were some local health departments that were concerned that maybe there were pockets of people or camps of people back in more remote areas that were really sick or maybe even dying and not knowing why, not having any idea what was going on. And so we did not find that, by the way. We did go into several rural areas and we did not find that at all. Of course, the projections, a lot of projections in the spring were that perhaps this was really going to devastate the homeless population, and that there would be I remember reading reports speculating that there may be thousands or tens of thousands of people who would get coronavirus and maybe even die. And so thankfully that was not the case, and certainly not the case here in Tennessee. And it has not severely impacted the homeless population the way that many people were initially concerned that it would. But I did meet people like Chuck. And Chuck was a gentleman that I met. He was living outside of a fairly large city in East Tennessee. He'd lived with his mom for most of his life. By his description, it sounded like he'd been diagnosed with some sort of intellectual disability as a child and had also struggled with some substance abuse off and on. He felt like he was really doing well with that, but that was part of his story as he told it. And also had struggled with diabetes. He had really severe diabetes. He'd lived with his mom until about 10 years ago when she had passed away, and he'd moved into this trailer. And it didn't have hot water and it didn't have electricity. But he was actually doing really well. I think probably up until the pandemic, he was doing really well. He would go into town to get hot meals from time to time and to do laundry. There was some sort of TV repair shop there that would pay him to unload their truck once or twice a week, and so he had some spending money. He had really good connections at a local health center where he had a case manager who helped him with his diabetes. Sometimes they would come out and visit him. Sometimes he would go in and meet with them there. He had an AA group that he was very involved with and some really good friends there that were a big source of support for him. And he had really strong connections at the behavioral health center, and he had a case manager there as well. So he had really extremely resilient gentleman and had really had some strong supports until March. When I saw him, he looked really rough. He was limping. He had some wounds that were really bad. He had a couple of fingers that were totally black. He was very dirty, which from based on him telling his story, that was unusual. And he looked really rough. So we asked him if he, was familiar with coronavirus, and he said that he was, and he said, in fact, I have it. And he already told me that he had not been into town for a couple of months. I think this was in May, maybe. And so that was a little puzzling to me. And I said, well, when were you tested? And he said, well, I don't know when I was tested. I don't know when that happened. All I know is that I guess I have it. And so he began to explain that one day he'd gone to work and his boss had told him that he couldn't come to work because of coronavirus. And he'd gone to his support group and they had said that he could not come in the building because of coronavirus. And that he tried to make an appointment with his case manager in the clinic, and they had said that he could only talk to them over the telephone because of coronavirus, and he didn't have a telephone. And so you can see where I'm going with this. Chuck had interpreted each shut door personally and had concluded that he must have coronavirus, he must be contagious, and that everyone, for some reason, everyone knew it other than him. And so I tried to explain that that was not the case, that precautions had been put in place and social distancing and state guidelines, and we tried to explain some of that. And he kind of looked at me and he said, so what you're saying is I'm dying from a disease that I don't even have. And in a lot of ways that was true. He was absolutely right. His diabetes was absolutely out of control. His primary source of food had been compromised. Every support that he'd had was gone as a secondary result of COVID-19. And so he really was, in a lot of ways, dying as a result of a disease that he didn't have and that, based on his lifestyle, he was probably never going to have. And so a lot of what we're facing as service providers is that kind of scenario, is that on the one hand, we have the reality of COVID-19 and the reality that we're working with a vulnerable population in many ways. And so trying to do what really must be done in order to prevent the disease and in order to treat those that may have it or that have it. And then on the other hand, on the other side of this seesaw sort of thing is the reality that those that we serve are suffering as a result of all of the precautions that even we and others have put in place. And so we're in a very awkward place. We're sort of walking this really bizarre balance beam that seems almost absurd in some ways. As I explained it to Chuck, I was really hit by sort of, oh my goodness, this is just bizarre. And so as we talk about COVID-19, that's what we're going to really talk about, is how do we walk that balance beam? And I can't in 30 minutes or in any amount of time tell you exactly how you should do that, but more just to talk about the reality that is what we're doing and what are some basic things we can keep in mind as we do that. So as we move forward, these are things that I'm going to assume you've already done, and I'm not going to spend a whole lot of time talking about these, but I do think it's important just to mention the reality of these different things and the importance of doing it. So as we quickly go through this list, and as you look over this list, if there's anything listed here that you have not done, that your agency has not done, I would highly recommend that you do so. These are things that everyone, no matter what you're doing, if you're serving the public, you should do. The Centers for Disease Control has a website specific for those who serve the homeless. Again, probably everyone listening to me has already visited that, but if not, that would be really important to do. They regularly update the site. As I was preparing for this webinar recording, they had not made an update in about a month. And so it's not something that you necessarily have to check every day unless something's changed, in the community. But the CDC and Housing and Urban Development, HUD, both have very specific guidance for those who serve the homeless as they deal with C-19. And those would be very valuable websites to regularly check and to receive updates from. Our website is the nhchc.org, and we also have a lot of resources there around COVID-19. Obviously, homelessness and healthcare is what we do. And so when there are updates from government agencies, we try to post them there. We have a lot of webinars and all kinds of things that you can read and watch, all kinds of resources around this topic, and we do keep that updated. So our website, or having similar websites like that you find to be helpful, that the layout you're familiar with, is going to be really important just to keep you up to date. Knowing and understanding your state and local guidelines when it comes to mask mandates and the number of people you're allowed to have inside of a building, things like that. Those vary from county to county, and those can change on a moment's notice. So keeping up with your local news and ideally even having connections in your local government who notify you when guidelines are about to change. And then connections with your local health department. Ideally, you will have someone at your local health department that you know by name, who has been to your program, who understands the layout of your building, who understands what you do, and the resources that you realistically have to do that. Your local health department is your number one go-to resource when it comes to COVID-19 or really any infectious disease. And so having someone there that you know well, you know their extension, they know you by name, is going to be really helpful, especially if anything changes. And then trusted team members from the medical community, whether that's on your board or someone who's just willing to be on call, but someone, whether a doctor, a nurse practitioner, a nurse, someone that you can call who, again, has been to your program, who knows how it works, and who can answer questions would be really helpful. And then having a decision-making body informed by appointed staff members. And one real challenge that a lot of programs have faced, especially initially, is that all staff members, all board members, all donors were getting these just tidal waves of information, and shelter program directors and shelter directors were getting just all these emails and links and articles, and it was impossible to navigate. And that if that's still happening, then it's going to be really important to appoint one or two staff members whose job it is to filter through that information and to only bring to the decision-making body what is appropriate for shelter and what is reliable, probably primarily coming from the websites we've cited above. And then this decision-making body that is comprised of people, again, very familiar with your program, intimately aware of how the building's laid out, the resources available to you, who take that information and then regularly meet and decide how are we going to move forward. If you put protocols in place, the third week of March, and nothing has changed since then, it would probably be a good idea to make sure that you have that decision-making body that is regularly reviewing what's happening. There were a lot of things put in place that aren't really necessary anymore. There may be lots of things that are necessary that weren't necessary then or that we didn't understand then. And so having a group of people who are regularly reviewing your response and making sure that it's still appropriate. Whenever we talk about communicable disease or infectious disease in shelter, we always talk about it from two different angles, and that's prevention and treatment. And really, in a lot of ways, this is no different. What's different about C-19 is that it's global, is that there are state guidelines that have been put into place, is that programs like yours at times are getting lots of attention from the public, who are afraid you're not going to respond appropriately or afraid that you're not doing enough. So that certainly makes this unique. But the reality of infectious disease is something that we've dealt with in the past. Most of us, if we've been doing this for any length of time, have had to sit down and talk about, okay, how are we going to respond? We have someone in shelter with tuberculosis, or we have someone in shelter with H1N1, or we have someone in shelter with hepatitis. How are we going to respond? How are we going to prevent it from spreading? And how are we going to treat those who are sick? And in its most basic form, that's what we're doing here. And so to whatever degree that we can kind of demystify C-19 so that there's no paranoia, there's no fear, there's no irrational decisions being made by anyone, so that just like every other infectious disease, it's not dominating your program. Those are the steps that hopefully you're taking at this point. This is not the main thing that we do. We were not designed to fight C-19. That's not our primary mission. So given our primary mission, how are we going to respond to this infectious disease? And it's going to be, in its most basic form, the same way that you've responded in prevention and treatment to other serious infectious diseases. And so all of these things you know, but how can we make it so that this is not our guiding force? This is not the needle of the compass. We don't do everything through the lens of C-19, but rather this is our program in light of the reality that some people may get sick. What do we do? Can really be helpful as we think about moving forward. So in prevention, we're going to talk about prevention in a lot of ways is the same steps we've taken to prevent other infectious disease. Hand washing is, do you have safe, accessible places for guests to wash their hands? When you think about the bathroom in your program, would you feel comfortable going in there and washing your hands regularly? If the answer is no, then you've got a problem, right? If the bathroom is a scary place, if it's difficult to get to, if it's not really accessible, if there's no hot water, if the handles don't work, if it's leaky, if there's no paper towels, there's no soap, then that's an issue, and that's something that you've got to address. And that's not just for C-19, that's for all infectious disease and even just good personal hygiene. Making sure that people have plenty of space. We're using the phrase social distancing, obviously, but this is something that's probably always been a little bit on our radar. Even when we just had an outbreak of head lice, right? We would start to think, all right, where are the places where people are congregating? What do we need to do about that? Same issue, making sure there's plenty of space. What are the times during the course of the day when people tend to be standing around in close proximity together, when they have to all wait together for something? And what can we do to spread people out? How close are they sleeping? How close are they coming to each other? What can we do to make sure everyone has plenty of space? What can we do to make sure staff have plenty of space? Do we need to use something like plastic shields? Is that necessary? If it is, okay, then let's do that. But what do we need to do so that people are able to do the work they've been given to do and still be safe realistically? And then keeping personal items separated so that razors, toothbrushes, bars of soap, things like that everyone has their own personal space for those and they're not all grouped together. That dishes and laundry are properly washed and stored, that everyone knows how to use the dishwasher and no one's opening up the dishwasher unsure if it's clean or dirty and pulling out dishes that may be dirty. Just simple kinds of things like that. And that all surfaces are sanitized regularly. This list, again, should look really familiar. These are the kinds of things we've been doing, especially as we enter into influenza season for years. Same kinds of things are going to keep people healthy in light of COVID-19. And then as we move from prevention, we always look at infectious disease from the lens of prevention and from the lens of treatment. Do we feel the need to screen people who come in? As we look at screening and testing, and we're not going to spend a whole lot of time on this, but as we look at these two topics, the CDC, the Centers for Disease Control, has not mandated testing or testing for homeless shelters. That's not something you have to do. And so you have some leeway here. There are programs that are testing everyone who walked through the door. There are programs that aren't testing anyone and are just responding to symptoms. If you're sick, we're just going to isolate you. You're going to be given the option to isolate, and here are your options. So what is best for your program? What if anything is mandated in your county, and then how do you wish to respond? So having options, whether you're testing or not, having options for those who are sick or for those who test positive, and then having options for those who have been directly exposed, and then options for those who are vulnerable is going to be really important. Just knowing, even if you've not had one guest with C-19 up until this point, having a plan. You may have had 20, you may have had 50 guests with C-19 at this point. How did your plan work? Was that successful? Are there changes you need to make? But these are the groups of people that we need to have a plan for. If someone is sick or if they've tested positive, where are they going to go? What are the options available to them? Some shelters are designating specific areas of the shelter for people who are sick or who have tested positive. Some are utilizing hotel rooms. Some are coordinating with other shelters, and this shelter has room for those who are sick, but they're sending those that are well who would normally be in those rooms to our shelter. So are there people you can partner with? So what are the options? And then making sure that those you serve are aware of these options. It would seem, based on some research, which is difficult, honestly, that many people are not accessing services. They're not coming to shelters because they're afraid they're going to lose their freedom. And that has actually happened in some cities here in Tennessee, where people went to the shelter. There was mandated testing. They were required to get tested. They tested positive, and they were taken to a facility where they were not allowed to leave for 2 weeks, even if they had somewhere else to go. Or they were taken to a hotel room, and they were, in essence, locked in that room for 2 weeks. So you can imagine that even in the best of circumstances, if I wasn't living in crisis, if I wasn't, a survivor of trauma, that would be pretty intimidating. That would be pretty unsettling to me. So having everyone who comes to your program understand, this is our policy around testing. If you begin to show symptoms, or if you test positive, these are going to be the options available to you. Notice the language I'm using. These are going to be the options available to you. If you choose not to accept any of those options, you won't be able to access services here. If you feel as a program obligated to report that person to the health department, then you need to let them know that at intake and regularly throughout their stay, so that there are no surprises, right? We're all adults. We're respecting human dignity. We're respecting personal freedom. And so we're being really clear. This is our plan. This is what we're doing. This is what's going to happen if you begin to show symptoms of C19. So apart from the prevention and treatment of the actual disease, let's look for a minute at some of the secondary issues. Like I said, on the other side of sort of this weird seesaw that people who are homeless are experiencing. We know that there has been a significant increase in all of these things here at the top of the list. In some cases, more than a 100% increase. I've talked to agencies who've said they've had more clients commit suicide from March to August of 2020 than they did from all of 2016 to all of 2019 combined. This is a real issue. The people that we serve are suffering. And so mental illness and suicide has drastically increased. The rate of overdose and those who are seeking help for substance abuse has increased. There are call centers in the state of Tennessee that at different points during the pandemic reported as much as a 300% increase in the number of people calling to receive domestic violence services. School closings obviously cause unique problems for families living in extreme poverty. Limited employment options. I know that's not the case in every county. In some counties, there's actually an increase in employment options. But in some counties, there are now businesses that still have not reopened and that will not reopen. And so that has limited employment options for some. Limited internet options, the places where people would normally go to look for jobs, to update their EBT information, to contact their case manager, have closed in a lot of counties. And so inability to access even the way to access services has become more complicated. And then a lack of trust. We need to be very aware of the fact that for many of those that we serve, we're going to have to rebuild trust. It's not just going to be, okay, we've increased services again and now you can come back, or now you can actually come to the office, or, and just assume that everyone's going to be great with that and understand and be really flexible. For a lot of our clients have agencies that they trusted in for years and that they thought would always be there for them. Agencies that said our doors will always be open to you, and they were closed. They weren't accessible. That's no one's fault. That's not a shaming statement. It's just the reality. We just didn't have many options, did we, for some of this? And so understanding that a lot of our clients feel betrayed and feel like they can no longer trust anyone. And so to be intentional about how do we rebuild trust. And then a lot of those that we serve have either by choice or feeling forced to have gone into isolation in a more extreme way than they've ever had to before. And I talk to lots of people who feel like they've had a real increase in social anxiety. That I stayed at home for some period of time, and now I feel really, anxious about getting out. And certainly those that we serve may feel that way as well. That coming back into society, coming back into a program can be really scary. And so just being aware of that, what can we do to mitigate that fear? So part of all of that we've talked about so far all of that is part of creating a culture of health. And we could talk for hours about what it means to create a culture of health, an environment in your program that's healthy, an environment that recognizes the physical, social, emotional, mental needs of everyone present. But that's really important now as we navigate C-19. How do we appropriately prioritize physical health and safety? And how do we appropriately prioritize mental and emotional health? And is the environment we've created really leaning one way or the other? That's really hard to do right now, isn't it? And so I don't say that lightly. But the CDC uses this language around mask mandates for people who are homeless, and I thought it was really interesting. They said, that you should put a mask on people who have symptoms, and I know in some cities you'll be required to have everyone wear a mask whether they have symptoms or not. But then they said you can't require someone to wear a mask if they can't tolerate it. And I think that's really well put. We can create an environment that is absolutely as physically safe as possible, but that it's also intolerable. I talked to one program that they had sort of a big gymnasium kind of set up, and normally they would have beds all filling this gymnasium. And so for social distancing, they spread out the bunk beds, and they put bunk beds in the hall and other areas they wouldn't normally use. And then they hung plastic shower curtain liners on 3 or 4 sides of every bed. And so certainly that, I would think would provide more barriers between people and would be more physically safe. But what they discovered is that when people woke up in the middle of the night, surrounded by plastic shower curtain liners, it was terrifying. It was absolutely so creepy. And so they realized that while they created an environment that was physically safer, emotionally it was intolerable. People could not sleep there. And so they had to make some changes. So a good question to ask yourself, is this tolerable? I come home every night, every restaurant I go to, every store I go to, I stop and I see what are the list of rules for this store. What do I have to wear? What do I have to do? When I come home, there's no list of rules on my door. And that's not true for those that we serve. There isn't that safe place. And we've talked about that, of course, across the board. But that's so much more true now in the situation that we're in now. So is this tolerable? Does it recognize human dignity? Are we continuing to give people choices? There's so much language now with C-19 around this is what we're going to do with people who are sick, and this is what we're going to do with those who won't take a test, and this is where we're going to put people who are sick. And really talking about people as if they are, as if they're chattel, as if they're pieces who can be rearranged on a board. I understand that's not intentional. I may have even used that language during the course of this presentation, but it obviously isn't helpful and not appropriate. What can we do so that people still have the freedom to make decisions about their own care, about their own quality of life as much as possible? And are we treating people with dignity and with respect? Lastly, I would just encourage you that this is a time that really calls for courage. And I say that very broadly. I have no idea what you should do as an individual, what those boundaries look like for you. I certainly cannot tell you what you should and should not be doing as an agency or as an individual in order to stay safe or to feel safe. And I wouldn't begin to do that. But whatever you're going to do or not do, it is certainly a time for tremendous courage. And it is certainly a time to be intentional and purposeful about how we're going to respond, both as individuals and as agencies. I've talked to some people who've said, who were working in nonprofits, who said, we looked at the mission for our agency and we considered the cost, and we determined this just isn't something that's important right now, given what's going on in the world. I talked to an agency that provides books to children in homeless camps, and they said, given everything that's going on, we've decided our mission is not worth continuing in these circumstances. So consider your mission. Is your mission worth continuing in these circumstances? Is there still a need for the services that you provide? If your answer is no, then certainly you can do what that agency did, and that may be the most appropriate thing to do. If your answer is yes, there is still a need, our mission is still worthwhile, then how are you going to do that? And how are you going to do that as an individual, and how are you going to do that as an agency? What does it look like to be flexible, to be creative? We have always been those people in this field. We have always been, by the very nature of what we do, we are those who move toward the crisis. We are those who engage people that most of our friends wouldn't even make eye contact with, right? Not because we're better, but because we have this desire to help, because of who we believe we're called to be, because of what we believe, what brings life and joy to us. That hasn't changed. And so, given your mission, both personally and corporately, what are you going to do now? What does it look like to move forward? And it's going to require a whole lot of flexibility. It's going to require a whole lot of creativity, and it is going to require a whole lot of courage. For most of us, when we really stop and think about it, this isn't the scariest thing we've faced. I'm talking to people right now who've received death threats. I'm talking to people who've walked through some scary situations, and came out victorious, came out able to help people, came out able to continue with compassion and patience and understanding. And lives have been saved because of the kind of work that you do. That hasn't changed. I read a book by Julian of Norwich in March, and Julian of Norwich had lived through the bubonic plague and had lost a lot of, the bubonic plague, had lost a lot of family members. And as she considered all of that and her life and the relationships that she had and her faith, she said, "All shall be well, and all shall be well, and all things shall be well. Thou shalt not be overcome." And I believe those words are true for us today. COVID-19 will not be the end of the work that we do. It will not keep us from doing what we believe we've been called and appointed, and what we believe in doing, right? So I leave you with that today, that as we move forward today and all the things that we'll think about and talk about, and as you go back and process that information with your teams and with your spouse, and as you really consider counting the cost, to remember what you're doing is valuable, and this will not be the end of who we are or of what we do, and this will not be the end of those that we serve. I put my email address there. I'm looking forward to the question and answer session, and I'm also happy to talk to anyone via email. Thank you.